Thank you, everyone. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period. In order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen that you can see so you know how much time you have left. As a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our 3-day meeting. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker today is Mr. Joaquin Beltran.
Thank you for having me. Full transparency, I was a Biden-Harris 2020 regional director, currently a small retail investor of Novavax to support its vaccine's ongoing availability, vaccinated with 2 Pfizers, 1 Novavax, and never had COVID. My name is Joaquin Beltran, and today I am calling on the CDC to fulfill its specific mission to control and prevent disease. Here are the specific actions to take. 1, make Novavax's updated XBB 1.5 booster available upon manufacturing completion. 2, update booster guidelines for equal access and allow for multiple boosters to improve protection. 3, expand Novavax access to everyone 6 months and up. 4, bring back mask requirements in healthcare settings. And 5, bring back testing and data. Here are some stories on why these actions are important. My friend Robbie, who has been suffering from long COVID for years, her mother was recently in the hospital for a non-COVID issue. She acquired COVID in the hospital and died from that very infection, a tragic and preventable death. My grandma and my dad, who both have long COVID. My grandma, for whom I am a caregiver, who has been, they have been experiencing long COVID after their infections. Both have circulation issues and their quality of life has not been the same. Other friends, in trying to protect themselves, many have had to lie or go out of state or the country even to obtain a Novavax vaccine because of current language in the guidelines, specifically the line that reads, quote, but have not previously received a COVID-19 booster, and if they cannot or will not receive mRNA vaccines, end quote. This language should be removed immediately. Other friends who have lost all sources of income due to disability, and others who are currently in this very moment being evicted from their homes because of long COVID. These stories aren't unique to people I know. Millions are suffering and going through this suffering from long COVID and through this financial hardship. Moreover, hospitals are collapsing from shortages, from thousands of healthcare workers who have died from COVID, and many more who have become disabled, and from increased overall morbidity in the population from the CDC's de facto mass reinfection policy that creates cumulative risk of heart attacks, stroke, damage, brain damage, type 1 diabetes in children, and immune dysregulation, and much more. I am urging the CDC to take immediate action to protect our families and communities by 1, making Novavax's updated XBB 1.5 booster available upon manufacturing completion. 2, updating booster guidelines for equal access and allow for multiple boosters to improve protection. 3, expanding Novavax access to everyone 6 months and older. 4, bringing back mask requirements in healthcare settings. And 5, bringing back testing and data. Thank you so much for your time.
Thank you for your comment. Next, we have Dorit Rice.
Hello, my name is Dorit Rice. I am a professor of law at UC Law San Francisco, and thank you for the opportunity to again comment to the committee. I have 3 points to make. First, following the committee's careful, critical discussion of RSV vaccines both yesterday and today, the penetrating questions about the data and the thoughtful way of the discussion went, I'd like to thank both the committee and the work groups for their extensive work on this. These meetings always show the extensive data and work behind every vaccine's decision, with brims of information provided, though you have to boil it down to relatively short presentation. But more than ever, I think this meeting shows us how hard it is to make decisions when you don't have full information, which you rarely do, but this is a little more extreme than usual. It's exactly in this situation where we need the expert input of a committee like ACIP, even more than when the data is clear. I'd like to reinforce the committee members' comments that we need data before the committee gets to a vote. But I would like to finish by reminding the committee and CDC on this point that a vaccine recommended under shared clinical decision-making may be treated by doctors as less important and not recommended. I hope that any materials sent out will remind doctors of the risk of disease the vaccines are recommending for in this way, and set it out clearly that at least a discussion of the vaccine is recommended, that shared clinical decision-making shouldn't be don't talk about it, but should be at least talk about it. Second, since we discussed dengue and chikungunya vaccine today, and following yesterday's discussion of the reemergence of polio, I want to use those to remind everyone of the importance of covering this disease and looking for the safety of the citizens of our territories and as much as of the states, and generally the importance of addressing so-called neglected tropical diseases, which are not really tropical, including by funding and promoting vaccination against them. Thank you for highlighting the large burden of these outbreaks, both in death and in other ways they are harming. And of course, in this age of climate change and travel, diseases don't stay. They will be coming beyond their borders, and we need to look at them for more selfish reasons as well. A bit off topic, this is a chance to remind everyone of the importance of protecting our vaccine scientists from harassment. And to build on this last point, I want to remind people that although anti-vaccine harassment has always been part of the reality of people responding to misinformation, as several of our scientists can testify, it's been growing more extreme, more virulent, and the volume has grown. Although CDC and ACIP have an important role in providing good information, they're not going to be in the front line of debunking, but I hope CDC makes sure that its scientists and ACIP experts have the support and protection they need to do their job safely and with resources and answers when harassed. And I would encourage other institutions to support scientists who speak up as well. Thank you.
Thank you for your comment. Next, we have Patricia Neuenschwander.
Good evening. I would love to stand before you and commend this committee on their rigorous evaluation of high-quality studies used to make recommendations, but I can't. I am a nurse who was a defender of vaccine safety and efficacy, a nurse who dutifully vaccinated her children and herself, confidently trusting that the CDC recommendations were based on rigorous evaluation of high-quality studies. I now know that was a lie. I sat yesterday listening to Dr. Talbot express her legitimate concerns over the RSV studies. When those concerns were not addressed, she did not vote no, she abstained. This is not scientific discourse. It is a pressure cooker for experts in the field to vote unanimously for anything that is put forward, giving the illusion of consensus. I want to focus the remainder of my comments specifically on the inadequate RSV vaccine science used yesterday and is being used today with pregnant women. They did not study the people who would potentially benefit, people over 75, nursing home patients, patients with the usual amount of comorbid conditions, or the immune compromised. Applying a questionable data from one healthy group to another group that has far more risk and yet not studied is scientifically unsound. Immunogenicity trials are inadequate. There are no established immune correlates of protection. We know nothing about additional doses or the co-administration with vaccines other than a small number who received a flu vaccine. The factual evidence presented from the grade evaluations did not show benefit with hospitalization, severe illness, or death, probably because the population used was healthy. We will never know now, but I'm sure that you will use suboptimal bias observational studies in the future to try and show it does. The actual science showed that it may reduce hospitalization for RSV illness, but the effect is very uncertain and a very low evidence type. It may impact severe RSV illness requiring supplemental oxygen and other support, but the effect is very uncertain and a very low evidence type. Yet you'll tell providers and the American people that it prevents severe disease and hospitalizations. These issues are not unique to the RSV vaccine trials. I have watched again and again as ACIP gave blanket approvals to COVID vaccines and boosters with equally questionable data. This is why you have anti-vaxxers. You are losing credibility and trust with frontline healthcare workers, and you have lost credibility and trust with the majority of Americans because you are allowing junk science and industry influence to determine your decisions. The CDC has settled too long for data that is poor, inadequate, or no data. It's time to modernize, demand rigorous science, embrace transparency, and engage in free and open debate, or the entire vaccine program will die. Thank you.
Thank you for your comment. Next, we have Dr. David Wiseman.
Thank you very much. Please see our written remarks. FDA has just advised developing XBB 1.5 COVID monovalents. This strategy seems destined to fail with a currently low death rate despite a 17% bivalent uptake. Do people agree with Dr. Offit that chasing variants is a losing game? Already 3 months after introduction, the bivalents were alarmingly evaded by XBB, according to Wang and other studies omitted from FDA's January brief. Cleveland Clinic noted that they were not alone in finding a possible association with more vax doses and higher risk of COVID. And last week, that COVID risk is lower in out-of-date than up-to-date adults. CDC interprets otherwise, but their data echoes others with rapid waning to negative VE, suggesting immune compromise. Rosine in Nature and FDA's brief suggest vaccination influences evolution and natural selection of escaped variants. We recall Dr. Long's comments in January 22 that repeated whack-a-mole boosting was unsustainable. Let's chase safety, not variants. Temporal associations between vax coverage and all-cause mortality persist. Why did it take until March for myocarditis to appear in Janssen's fact sheet and CDC and FDA to report this potential safety concern in the WHO paper? We flagged this signal to ACIP in late 2021. Why can't they find a stroke signal outside of VSD when it appears in CDC's VAERS PRR FOIA release in January? That same release shows cancer signals, but still no cancer, genotox, or mutagenicity studies. And yet the National Cancer Institute shows reverse transcription is possible. NIH show message and spike enter the nucleus. Episomal transmission does not need integration. FDA's Dr. Peden writes, DNA can be oncogenic. There are reports of possibly replication-competent residual plasmid template DNA with antibiotic resistance and undisclosed SV40 promoter sequences at levels above guidelines, suggesting adulteration. Excluding these gene therapies from guidance does not change biology or safety concerns. FDA extrapolates further the chasm between EUA may be effective and the regular safe and effective standards. The bivalents yield novel heterotrimers with untested tox and likely misbranding. Dr. Sanchez's question last year about spike kinetics remains unanswered with no FDA insistence for these studies. Lipid nanoparticles widely distribute. Spike persists for up to 4 months, mRNA up to 28 days. If you can't say where and for how long these gene therapies induce spike production, you shouldn't be asking people to vax. Dr. Fauci in Cell writes, vaccines have never effectively controlled these sorts of vaccines and are not expected to do so. Dr. Marks in JAMA questions incrementally modifying variant-specific vaccines. Regulate these products as gene therapies. No free passes to poorly understood platforms.
Thank you for your
Consider
comment. Your
cumulative
time has
toxicity
expired.
and chase safety, not variants. Thank you very much.
Next, we have Mr. Burton Eller.
My name is Burton Eller. I'm the Executive Director of Advocacy for the National Grange. Founded in 1867, the Grange is the oldest national organization advocating for Americans living in rural and small town America. Our mission is to work together to support and advance the safety, health, economic security, and well-being of those who have chosen a rural way of life. We are here today to continue our effort to highlight the vulnerability of our communities to respiratory diseases and to share our support for ensuring that older Americans most vulnerable to RSV have access to the newly FDA-approved vaccines before the start of the respiratory season. As you may know, rural Americans face an elevated risk of serious illnesses from respiratory diseases. These are due to a number of factors, including the fact that rural Americans are less likely to have health insurance and have less access to health care as more and more rural hospitals are closing their doors. A lack of reliable broadband also limits rural Americans' ability to access healthcare services. Additionally, rural areas have a higher percentage of Americans aged 65 and older versus urban areas. While the COVID-19 pandemic in ways helped shine light on the positive aspects of living outside of cities, the resulting migration of urban residents to rural areas has also put an added strain on our already limited resources. As we saw more adults suffering from RSV last fall and winter, it was almost reminiscent of the beginning of the COVID pandemic. News outlets throughout the country were once again reporting the challenges the remaining rural hospitals faced as they tried to cope with the influx of patients needing care with no space to offer them. Fortunately, with long-awaited development and approval of an RSV vaccine, we have the tools to protect ourselves. We thank the committee for your thoughtful consideration of who would be the best served by these vaccines, but we are concerned that these vote for the shared clinical decision may create a rather disproportionate impact on rural seniors. Rural providers are stretched thin, and their patients tend to be older and sicker. In urban areas, there are 31 physicians for every 10,000 people, compared to just 13 physicians in rural areas. And there are fewer clinical facilities like clinics and pharmacies. While we believe every American should have the choice of whether to receive a vaccine, we also want to ensure equitable access to the information of what vaccines are available and why they are so important. For rural seniors who do not have easy access to their clinician, any extra step, we fear, could reduce the likelihood that these patients will gain access to these protections. Regardless, we are encouraged by those aged 60 years and older who will have the opportunity to consider a protection against RSV and hope the recommendations are reconsidered in the future as we have more data to indicate whether these most vulnerable communities are truly and adequately being served. Thank you.
Thank you for your comment. Next, we have Ms. Elizabeth Dietz. Ms. Dietz, are you on?
Yes.
Please
My
go ahead.
name is Liz Dietz, and I live in San Mateo County, California. Thank you all to the committee for the time and expertise that you donate to the nation to improve public health. I'm especially grateful to Dr. Camille Nelson Cotton this morning for sharing on Twitter the key benefits of the RSV vaccine. I am speaking as a potential RSV vaccine recipient. I am over 65 and have other risk factors for infection with RSV. I am grateful that the committee voted to approve the vaccine, and I'm disappointed that the recommendation is that my age cohort may get the vaccine with shared decision-making rather than we should get the vaccine. Here's why. I've been an advocate for vaccines in my community for both in person and online for over 20 years. Until relatively recently, I had no idea that RSV was a significant health risk for people over 60. I thought it was only a risk for infants, especially those born prematurely. It's hard to sell a health intervention like a vaccine if the intended recipient has no idea that the disease prevented is a risk for the recipient. Most people in my age cohort that I know were eager to get the shingles vaccine because the suffering caused by shingles is common knowledge. Most people in my age cohort that I know have been vaccinated against pneumococcal disease because the significant drop in quality of life, hospitalization for pneumonia is common knowledge. Most people in my age cohort that I know do take an annual flu vaccine because the risk of flu in our age group is common knowledge. And yes, many in my age cohort do get their flu vaccines and others through vaccine clinics or pharmacies. In other words, the vaccine recipient drives the decision to get the vaccine, not a physician or other healthcare provider. We are in a dangerous era where influential sources are blatantly anti-science. What is the plan to explain to older Americans that this is a disease that not just kill, but significantly impair their quality of life? After an ICU stay and hospitalization, it takes a while to return to pre-illness baseline of quality of life, independence, and mobility. Because these vaccines will be covered under Medicare Part D and thus administered in pharmacies rather than physicians' offices, what is the plan to educate not just the vaccine-given pharmacists, but all client-facing pharmacy staff to educate elders? I appreciate that the committee voted for may rather than shall because of a lack of data. What is the plan to collect post-approval data, especially in the 80 and over age cohort? What is the plan for this committee to reconsider this data and to change may to shall? Again, thank you all for your hard work, and I hope that this vaccine will be reconsidered soon.
Thank you for your comment. Next, we have Shinsuke Yamamoto.
Hi, thank you. My name is Shin Yamamoto. I'm a husband and father of 2 kids, aged 3 and 9, and a member of the group Protect Their Future, a nonprofit advocating for equitable healthcare and COVID-19 vaccine access for children of all ages. We've led a fairly cautious lifestyle since March 2020, between waiting for vaccinations for all of us and trying to reduce adverse outcomes for my wife, who is now on a B-cell depleting therapy for her relapse and remitting multiple sclerosis. Considering the prevalence of autoimmune diseases and other chronic illnesses in this country, I don't think we're an isolated case. Many like us have had to make hard choices and accept an elevated level of risk that comes with reintegrating society. I support and welcome the updated COVID-19 vaccine boosters coming from various manufacturers. I would, however, like to see simultaneous availability across all ages, which we have not had up to now. This is the most equitable option and one that will ultimately help those of us most at risk who still have to balance our health and the daily lives of our families. Accessibility for pediatric vaccines has been an issue, and I would like to see that addressed as well. Finding a vaccine for your kids should not be as difficult as finding a popular Christmas toy in stock. The same thought applies for any vaccination for RSV, which was a cause for so many sick kids in 2022. That is all. Thank you.
Thank you for your comment. Sorry, with that, our public comment section has ended. I want to thank all of our public comment speakers today who volunteered to call in, and also for those who have provided written public comment. We appreciate the public input to our deliberations. At this time, we are going to move to the vote section of the meeting. I'm going to remind my colleagues that we will have to turn on our cameras when we do the vote, so if you could please just prepare your areas, that would be wonderful. And we're getting the votes up there. Dr. Kobayashi, I'm going to ask if you will take us through the votes one by one, and please read them out loud. We have 4 motions on the table, I believe, for pneumococcal vaccines.
Thank you very much. Okay, so the first policy option is on routine PCV use for all children aged under 24 months. Use of either PCV 15 or PCV 20 is recommended for all children aged 2 to 23 months according to currently recommended PCV dosing and schedules.
Thank you. Sorry, we're just getting our voting pages set. I'm going to ask people to mute. Is somebody unmuted? Are we good? Are we muted? Okay, perfect. Thank you. Thank you. And with vote number 1 on the table, I'm going to start with Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Cotton?
Camille Cotton, no conflicts, yes.
Dr. Long? We're going to skip over Dr. Long. I'll come back. Dr. Sanchez? Dr. Brooks?
Oliver Brooks. No conflicts. Yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Daly?
Matt Daly, no conflicts, yes.
Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Lair?
Jamie Laird, no conflicts, yes.
Dr. Chen?
Wilbur Chen, no conflicts, yes.
Dr. Talbot?
Talbot, no conflicts, yes.
Lee, no conflicts, yes. Dr. Paling?
Paling, no conflicts, yes.
Dr. Long?
Sarah Long, no conflict, yes. Here, Pablo.
Okay, it's not me this time.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Bell?
Bell, no conflicts, yes.
Thank you. Dr. Warden?
So vote number 1 passed 14-0.
Thank you. Dr. Kobayashi, if I could have you please read vote number 2.
Yes. So the second policy option was updated to clarify the two groups who are recommended to receive the catch-up doses. So catch-up PCV doses for children aged 24 to 71 months with an incomplete PCV vaccination status. For children with an incomplete PCV vaccination status, use of either PCV 15 or PCV 20 according to currently recommended PCV dosing and schedules is recommended. For healthy children aged 2 through 59 months and children with specific risk condition aged 24 to 71 months.
I'm going to do the Zoom screen, so I see Dr. Cotton first.
Camille Cotton, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Talbot.
Talbot, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Bell.
Sorry, I lost my cursor. Bell, no conflicts, yes.
Thank you. Dr. Saneas.
Sybil Saneas, no conflicts, yes.
Lee, no conflicts, yes. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Ms. Bata.
Lynn Bata, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Daly.
Daly, no conflicts, yes.
Dr. Long.
Long, no conflict, yes.
Dr. Lear.
Lair, no conflicts, yes.
Dr. Paling.
Paling, no conflict, yes.
Dr. Wharton.
Thank you. We have a unanimous vote in support of the vote on the question, the vote on the board.
Thank you. So vote number 2 passes, and we'll move on to vote number 3. Dr. Kobayashi.
3, children aged 2 to 18 years with any risk condition who have completed their recommended PCV doses before age 6 years. For children aged 2 to 18 years with any risk condition who have received all recommended doses before age 6 years, and if the PCV dose included at least 1 dose of PCV 20, no additional doses of any pneumococcal vaccine are indicated. This recommendation may be updated as additional data become available. If the PCV was based on PCV 13 or PCV 15 with no PCV 20, a dose of PCV 20 or PPSV 23 using previously recommended doses and schedule is recommended.
We'll start with Ms. McNally.
McNally, no conflicts, yes.
Ms. Bata.
Lynn Bata, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Paling.
Paling, no conflict, yes.
Dr. Long.
Long, no conflict, yes.
Dr. Cotton.
Camille Cotton, no conflict, yes.
Dr. Saneas.
Sybil Saneas, no conflict, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Daly.
Daly, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Chen.
Wilbur Chen, no conflicts, yes.
Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
And Lee, no conflicts, yes. Dr. Wharton.
And the vote passed unanimously.
Thank you. So vote number 3 passes, and we'll move on to vote number 4. Dr. Kobayashi.
children aged 6 to 18 years with any risk condition who have not received any dose of PCV. So this language was also updated based on feedback. So instead of adding certain scenarios where children might have received PCV7 or PPSB23, that will be included in clinical guidance to clarify. So currently we say, for children aged 6 to 18 years with any risk condition who have not received any dose of PCV13, PCV15, or PCV20, a single dose of PCV15 or PCV20 is recommended. When PCV15 is used, it should be followed by a dose of PPSB23 at least 8 weeks later, if not previously given.
Thank you. Dr. Bell?
Bell, no conflicts, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Cotton?
Camille Cotton, no conflict, yes. Yes, to be clear, and no conflict.
Thank you. Sorry. It's been a long day. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Dr. Talbot?
Talbot, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sineas?
Sybil Sinaya's, no conflicts, yes.
Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Daly?
Daly, no conflicts, yes.
Dr. Paling?
Paling, no conflict, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Lee, no conflicts, yes. Dr. Wharton?
And the vote passed unanimously.
Thank you. So the fourth vote passes. Thank you for the revised wording that was helpful and for the additional commas for Dr. Long. And now we will move on to the VFC vote, which will be up next. Okay. For the pneumococcal vaccines VFC vote, Dr. Santoli, do you want to read the vote?
So this vote is about approving the VFC resolution for pneumococcal vaccines.
Okay, I'm going to make it easier for my colleagues today. I'm going to start with Ms. McNally and go down the line.
McNally, no conflicts, yes.
Dr. Daly?
Daly, no conflicts, yes.
Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Dr. Chen?
Wilbur Chen, no conflicts, yes.
Dr. Talbot?
Talbot, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, yes.
Lee, no conflicts, yes. Dr. Paling?
Paling, no conflicts, yes.
Dr. Sineas?
Sybil Sinaya's, no conflicts, yes.
Dr. Cotton?
Camille Cotton, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
And Dr. Brooks?
Oliver Brooks, no conflicts, yes.
And Dr. Wharton?
And the VFC resolution was unanimously approved.
Thank you, everyone. Thank you for your work today. So that concludes our votes for today. Let me just check to see. Well, let me just start with a thank you to all of our speakers and our ACIP ex officio and liaison members for your work. We are going to check with Dr. Wharton to see if we have any further business for today. We still have another day tomorrow.
We do not. No additional.
Oh, no,
business.
I thought you meant we had no day tomorrow. Okay.
No, we can adjourn.
Okay.
We have to come back tomorrow.
Any objections to adjourning? Oh, thank you. See, Dr. Lair is my conscience here. If anyone would like to make any comments on their vote, please feel free. Okay. I don't see any hands raised, but I appreciate the point of process there and Dr. Lair for giving people the opportunity to speak. With that, we don't have any further business, so we will adjourn today's meeting, and we will see you tomorrow. Thank you, everyone.